So my name's Carlene Macmillan. I'm an adult and child psychiatrist. I run a private group practice in Brooklyn, and I'm also the psychiatrist for the Ellenhorn Private Assertive Community Treatment Program here in New York, where we treat a lot of complex patients, including many with personality pathology. So today I'm really going to be talking about attitudes that child psychiatrists have about working with folks with borderline personality disorder and some steps we're taking to hopefully improve that. It's just where I work. So as a child psychiatrist who kind of self-identifies as someone who enjoys working with this population, this is kind of a prototypical referral that I actually got earlier this week. So an 18-year-old girl just diagnosed on an adult inpatient unit with borderline, was previously told that she had bipolar 2. She meets 9 out of 9 criteria for borderline, comes to see me upon discharge. Mom says she's been going to therapy twice a week. She's been taking meds for years. She was even hospitalized on an adolescent unit. Why didn't anyone tell us she had BPD? Similarly, when I was trying to review medication history with the patient, she said I would tell my psychiatrist I felt empty and suicidal. They would add a medication. I don't know if any of them help. I still feel empty and suicidal all the time. Very, very typical. Now, why does this type of referral come to me? Well, so I trained and worked in what I think of as sort of the McLean utopian bubble, where I was steeped in DBT, MBT, good psychiatric management, and had the privilege to be surrounded by mentors and supervisors who were very enthusiastic and talented at working with this population. About 2 years ago, I moved to New York, and while I think there's a very solid community of adult psychiatrists very interested in this, very, very few child psychiatrists are actively seeking this type of work out. So I was inspired by the work of Gunderson and colleagues to roll out good psychiatric management curriculum across the country. This has really been aimed thus far at adult psychiatry residencies. But child psychiatry training really lags behind. It just has not trickled down and been adapted to that group as of yet. Didactics on personality disorders, even at my program at MGH McLean, the amount of didactics that we got just built into the curriculum was very, very small compared to adults, and I had to actively seek out, that elective time. So what we're going to talk about today is kind of steps that we're taking to improve this. I'll first go over just a brief needs assessment survey I did. We'll then talk about a series of presentations we did at the annual meeting for child psychiatrists this past year. And then as a result of that, kind of next steps that are in place. So I decided, I have this hunch that child psychiatrists aren't making this diagnosis so much, but let's see. So I went on to Facebook, where there's a very, very active community of psychiatrists in the Psychiatry Network, Women's Psychiatry Network, and then just my own newsfeed, which has a lot of mental health practitioners, looking for folks that work with children. And I asked them a quick survey about diagnosis and comfort in working with borderline personality in young people. And I looked at both some qualitative and quantitative responses. So who responded to my survey? Well, 82 people. And as you can see here, it was a pretty normal distribution from anything from 1 to 2 years out from medical school all the way up to 30. And the vast majority of folks were in the sort of early career psychiatrist range, so really kind of the future of our field. Now, I think a limitation to keep in mind is this is an opportunity sample, a self-selecting group of psychiatrists who are already, active on this forum, and then people in my newsfeed that, I know. So I think if anything, this is probably overestimates the level of savviness, and I think you'll see there's still much work to be done. So the first question was simply, how comfortable are you working with this population? And I think here we have a little bit of the Lake Wobegon effect, where everyone's better than average. So 43% said they were somewhat more comfortable than peers. 35% said average. Only 8% said that they were very comfortable in actively seeking out cases. Only 2% said they always refer out, and then 11% said somewhat less than peers. Now, what I thought was interesting about this was when I looked to see, does years of experience actually seem to have any relationship with comfort level? And the answer was no. Unlike something like ADHD, where the more I see ADHD, the more comfortable I get, it seems psychiatrists are kind of self-identifying as someone that works with people with borderline and someone who doesn't, regardless of how many years out they are. So this is an example of someone at the extreme always refer out. So they say PGY 6, meaning 6 years out from medical school. I'm not very comfortable working with borderline personality. I have a lot of countertransference, and I'm only doing 15-minute medication management checks, so I'm limited in possible interventions. And I think what we know from a good psychiatric management perspective is that you actually have quite an opportunity in those 15 minutes to do no harm, right? To think about what meds they're on, think if they're necessary, pull them back, and really be thoughtful and provide some psychoeducation. Then on the other end of the spectrum, this was someone who said that they were actively seeking these cases. I don't know why so many child and adolescent colleagues are still so reluctant to diagnose, despite data out there, which we have loads of today. But I probably forget how anxiety-provoking this line of work was when I had less experience with borderline. So looking a little bit further about, okay, people say they're comfortable, but are they actually making this diagnosis? So in terms of how often it's being diagnosed in adolescents, you can see this skews to the left. So never, rarely, sometimes, very few saying often, no one says very often. Looking at this graph, you would think that patients with borderline were rare occurrences in our outpatient and inpatient settings. This is not the case. So compared to adults, when they've looked and done structured interviews in these settings, we find about 11 to 28% of psychiatric outpatients in an adolescent clinic are meeting criteria, and 43 to 53% of psychiatric inpatients on child units. General population amounts are still roughly the same, and I would say from my clinical experience, these numbers make sense. So something's not adding up. Similarly to comfort, it really didn't matter how many years of experience you had in terms of how often you were diagnosing this. So I then asked what factors contribute to whether or not you're making this diagnosis, and people could select as many as they wanted. So almost a third of people said it depended on whether or not the person was 18 years old. Similar numbers said they don't make the diagnosis because it's too stigmatizing. Over 50% of people said, it's very hard to distinguish between sort of normal adolescent development and borderline pathology. Very few said it was because there wasn't evidence-based treatment available. Fewer yet said they didn't like the name. I'm personally not a huge fan of the name, so I'd fall into that. And then few said they don't like, they'd prefer to have a dimensional model. Encouragingly, there was about a third of people who said, they actually do make the diagnosis because they're finding it validating and hopeful for the vast majority of people they're working with. And then about a third said that they tend to use terms like borderline traits or other specified mood disorder or the new disruptive mood dysregulation disorder added to the DSM-5. So I wanted to look more closely at this 18 thing because this is a huge myth in our field. So this PGY-5 says quite succinctly, can't be done before 18, should be later. Okay, so this is a myth. Borderline personality disorder in DSM-4 and DSM-5 can be diagnosed if symptoms are present for at least a year. I can't tell you how many times I've had to tell people that. When people will say, well, I know you can't diagnose it until 18, but, right, and what we know is that temperament emerges early in infancy. We know that, from Zanarini's work, these traits are evident very early on, long before someone magically turns 18 and receives the diagnosis, just like the patient that I saw earlier this week had happen. So I think you guys probably know this, but just some reminders about what are the consequences of delaying diagnosis in this manner. They end up being misdiagnosed. Bipolar disorder, treatment-resistant depression, they don't get access to the evidence-based treatments we know work during key phases of development. They end up on a lot of medications with a lot of side effects and also a sense of disillusionment because they're really not getting the results they hoped for. We know they end up chronic high utilizers of the system, and then we know from longitudinal data they are at higher risk for substance use, sexually transmitted infections, underemployment, school failure, and legal issues. And then I think finally it's important to keep in mind that in a population already vulnerable to being feeling invalidated, it's very invalidating to not make an accurate diagnosis. So this quote, I think, epitomizes kind of the tension in our field. So this is, I just started child training. It seems the culture of my institution is to wait until 18 for a formal diagnosis. In my opinion, if the patient meets criteria, I would diagnose any post-pubescent kid. I think beating around the bush does a disservice to the patient, reduces the quality of communication between providers, and delays the time for patient to get proper care. I think it's great, and unfortunately this person is being trained in an institution that's telling them otherwise. So this dilemma that many people had about distinguishing normal versus abnormal teen development. Joel Parrish and others have written very eloquently on this. And the bottom line is that most teenagers do not end up in emergency room after a breakup. They do not have profound abandonment fears. They generally attend school. And most, although cutting is common in terms of experimentation, for someone to then chronically rely on it is not typical. So I think with a little bit of nuanced training, you can sort this out. One person said, unbelievably still misdiagnosed and treated by professionals. Please keep up your efforts to educate not only the public but the profession. So that's what we're aiming to do. And we decided to first focus on the largest meeting of child psychiatrists, which is the ACAP meeting. And I had a hunch that BPD really was not an area of focus. So I looked from 2011 to 2016 at how often these disorders showed up in the program guide. And you can see, so last year, BPD 10, autism 135. We have huge discrepancies between these disorders. Bipolar is always well represented, as is ADHD. And conduct disorder also gets kind of the short end of the stick. I put that in there thinking of it as a sort of a marker for further antisocial. So I wasn't sure, is this just not interest? What is happening here? Are they not getting submissions? But in any event, it's really just, it doesn't have a seat at the table at this meeting. So when we looked closely at the year we presented, there were 6 posters related to this. There was 1 clinical perspective. A clinical perspective is a no-ticket required open event that includes multiple presentations, and that was ours. 1 media theater, the girl with the dragon tattoo, touched upon this, although it wasn't the focus. Interestingly, there were 5 ticketed workshops. These are up to 30 people each. People have to pay extra on topics such as DBT, MBT, and mindfulness. And then when they have different keywords, personality disorder is a keyword. I searched for it, and our presentation was the only one that came up. And there was no BPD keyword to choose from. So what we ended up doing was we entitled it Approaching BPD with Confidence in Young People, a primer for the general child and adolescent psychiatrist. I introduced the topic by bringing up some things from GPM regarding the prevalence, course, heritability, a lot of Zanarini's work, and a message of hope. We then had a family member named Rosa Novini, who's the co-founder of Emotions Matters, one of the sponsors of this meeting, speak very, very eloquently and very moving about her sister. We then had Francesca Perplechikova, I hope I'm pronouncing that correctly, introduce some work about DBT, and in particular her modifications of DBT for young children, so really thinking about kind of early prevention. Then Dr. Muir, who will be speaking next, gave kind of a bird's eye view of mentalization. And then I rounded things out by talking about some rational prescribing practices that kind of combine principles from various different approaches to borderline. And then finally, we had Dr. Bruce Hasek leading a short panel discussion. He's quite skeptical of this diagnosis, so we wanted to have another perspective at the table. I think we did not know if people would come to this. We really did not know what to expect. People came. There was over 249 people. The only critical feedback was that people wanted a bigger room for next time, and they wanted more time for discussion. As you can see, people were sitting on the floor, into the hall, and I would say this is not typical of presentations at ACAP. So there was despite very few presentations, there is a clear interest and hunger in our field for this. When asked if it should be offered again, everyone who responded said yes. Looking at this sort of quantitative data that they collect, we got all 5s and 1 4, about not enough time for discussion. This was on a scale of 1 to 5, and I think the one that sticks out the most for me was information from this session will change my practice. I mean, this is only a 3-hour thing, and so if we can at least, whet people's appetite or get them to change their thinking even a little bit, I think that's, a good start. So one comment that we received, I think, really hit upon this, that I came to the lecture already offended by the historical bias and unhelpful classification of borderline personality disorder, but was willing to change my thinking and learn, and I did. Thank you. So from this, a number of different opportunities have come up. People have approached us about doing workshops, grand rounds, working on a book, and then also for next year, we've combined forces with other folks that have interest in this from Menninger, Anna Freud, and UCLA to increase the numbers of presentations at this meeting. We would like to eventually interface more with child psychiatry training directors to really get this in the curriculum, similar to what GPM has done for adults. And then finally, I would really encourage folks here today, particularly folks presenting, to consider submitting to this meeting things that would be appropriate for a general audience, because there is a clear void to be filled. So wouldn't be here today without many of my mentors, my husband, Dr. Muir, John Gunderson, and folks at McLean, both at the Borderline Personality Training Institute and the Threes Curriculum Continuum, people like Blaise Aguirre, Emotions Matter, co-collaborators, and just the survey participants. Thank you.